be moderating. I'll be moderating the chat as well. I'll be directing all the chats from Feedloop to Zoom so that all the presenters can see. So I'll also turn on caption. All right, thanks everyone for joining our Lightning Talk session. So firstly, I'm just gonna go through how a Lightning Talk will work. So for each of the presenters we have here, so we have 7 presenters in total for today. And for each presenter, they will have 5 minutes for their presentation, and then they will have 3 minutes for question and answer. And then we have to move on to the next presenter. And then again, I will wave my hand just like this when you only have 30 seconds left. So for all the participants here today, you will be able to vote for your favorite presentation right at the end of the session. So there should be like a voting function that will pop up in Feedloop. So if you're like exiting the session, you won't be able to see that voting function at all. So first, I'll introduce our first speaker here today is Dr. Puya Azar and Chris Haslam. So please welcome Dr. Puya Azar, the head of the Complex Pain and Addiction Service, a consulting service under the Department of Psychiatry at Vancouver Coastal Health. And Chris Haslam, a professional skateboarder, as they talk about addiction, primary prevention, harnessing the power of celebrity influence in skateboarding culture. So of course, Puya, I will start the timer whenever you're ready.
Well, thank you for that introduction. It's a pleasure to be here with skateboard royalty, Chris Haslam, and we'll be talking about primary prevention. So much of my research has been focused on pharmacology, medical devices, treating addiction. But the thought was, well, what about preventing addiction from happening in the first place? So that's primary prevention. So the thought was to look at how primary prevention has already been done. And looking through it, it hasn't actually been done very well, very effectively. It's usually campaigns such as Just Say No or This Is Your Brain on Drugs, campaigns that don't necessarily work well in the first place. So then the thought is like, what actually influences young people in this day and age? And it's usually social media, celebrity influencers, etc. So the thought was, can we use modern marketing techniques and influence the power of celebrity influencers to propagate the message of primary prevention when it comes to addiction? So then the thought was, well, I grew up in skateboard culture, so can we do this using skateboard culture and the power of celebrity influencers within skateboarding? And that's how I connected with Chris Haslam. So now Chris is going to talk a little bit about how we're going to do this and why skateboarding lends itself well to this type of campaign.
So skateboarding is very self-driven. It's a very self-expressive kind of activity. I mean, regardless of where you come from, your background, or whatever you're going through in your life, everything that you learn in skateboarding is positive. I mean, the diversity you have in skating, everything that you learn and you put into the pot of skating, we take and we get inspired by that. So we don't really need coaches or teachers or anything of that. So with the creative mindset, you need a creative mindset as well to express yourself, maybe with the clothes, anything that you have that you bring into the pot that we can take is a positive thing for us. So even just the way that you look at spots and stuff, and like this is a little skate spot that people look at, is the way that you look at it. You can spend months trying to do something on this spot, which is a level of perseverance that not many other sports have. There's a lot of delayed gratification in spending a month skating things like this. Skating is very risky. It's very hard. There's a lot of low risk skating is what most of us do, but then there's also the very high risk skating that a lot of other people do. And there's people could be looking at these things for years, like years of their lives, saying that they're going to do this one day, and other people could be driving by in like 20 minutes and make a rash, impulsive decision at a very high risk activity that they wanted to do, and then go ahead and do something like this in very quick amount of decision making. But then they'll go into the novelty seeking aspect of it is they'll continue to do this throughout their whole skate career, regardless of whatever the risks may be, because it's celebrated, as you can see, with covers and stuff. And you know, when people take that kind of influence and risk behavior into other things of their other parts of the world, or other parts of society, it could potentially be hazardous. And these are just some of the things, like the effect that we can have on the kids that we are part of in our community. There's so many people that are in our community, regardless of age or ethnicity, able-bodiedness or whatever. Like, we influence all sorts of kids and people on the world stage, you know. And then the way that it influences society as a whole, in terms of like going through brands like Supreme and music and video games, you know, Jason Lee and acting, and you know, award-winning directors, and so skateboarding infiltrates into society pretty naturally. Actually, society looks at us pretty naturally to get it. So this is how do we harness this? And this is where we come in with the natural stance.
Yeah, so Chris very nicely outlined how this lends itself well to skateboard culture. So how do we use the power of influences in skateboard culture? Well, the thought was to create a platform where we can discuss with professional skateboarders their experience with addiction or mental health or other social issues that they may have interfaced with, and to provide that message not in a preachy, telling people what to do, but in a very natural manner, using people that young people admire. And as you can see in the previous slide, I mean, the influence that professional skateboarders have within skateboard culture is huge, to the point where people will tattoo professional skateboarders' faces on their body. You can see Chris's face tattooed on somebody's. I hope that's a leg. I'm not sure, but so if the influence is that profound that people are going to tattoo their likeness on their body, then we can harness that to deliver these messages, and hopefully the messages will be absorbed in a way that couldn't be absorbed if it's me as a physician delivering the same message. So we've been able to travel to different universities talking about this campaign. Here we are at Stanford, Harvard, Yale, and the response has been just remarkable. People are super excited about this approach to primary prevention. So how are we doing this? We're going to have a platform. It's called Natural Stance. We're going to have a podcast called the Natural Stance Podcast, where we're going to be interviewing people, delivering this message in a way that had outlined previously. And we're also going to have videos and a forum section, et cetera, et cetera. It's a work in progress, but the sort of big picture concept is that we're going to be harnessing the power of influence to deliver messaging around the harms of substance use, and to hopefully reduce stigma when it comes to discussing substance use as well as mental illness. I can end it there, and we're happy to take questions for the remaining time.
Awesome. Thanks, Dr. Azar and Chris. I'm just looking at the chat right now. So I can get started with the 3-minute question and answer first with my own questions. Mm-hmm. So I was wondering if you have any like specific strategies that can be implemented to effectively leverage celebrity influence in promoting addiction prevention messages within the skateboarding community.
Well, you know, it's a good question. We've already started doing it. Skateboarding culture is interesting because the level of peer influence is huge. And skateboarders will often listen to other skateboarders before they'll listen to anybody else. So to have somebody starting out, Chris Haslam, who is world-renowned, legendary skateboarder, co-hosting this with me, addiction medicine specialist. And if we're able to then interview other very well-known figures within the skateboard community, and if we can sort of naturally and organically talk about these issues, again, nobody's telling anybody what to do, but we're just sharing each other's experience. I think that can be absorbed in a very natural way by the audience, as opposed to campaigns where we're just telling people, just say no, or this is your brain on drugs. Those campaigns are much less meaningful.
Our level of celebrity within the skating is much different than the Lionel Messi's and LeBron James and stuff, because we go out and we're with these kids all day, every day. So we there's no barriers, no security guards, nothing like that. It's not, we're reachable for them. So, you know, they know our lives. We just become friends with all these people because of just how we are as a community in skating. So there's a level of approachableness that the other celebrities don't have, I find.
Mm-hmm. Yeah.
And what are the potential challenges or limitations of using celebrity influence of addiction prevention? Do you think there might be?
In skating, I mean, again, it's very delicate. If you force anything, it won't work. So we have to do this. It can be effective, but also could not be if we do it the wrong way. So we kind of have to figure out the correct way to do this, because we have a lot of people involved that, you know, could be hurt by this in terms of career and whatever like that. So it's very delicate to how do we do it without seeming pushy. And before it was so pushy, like the "don't do this is your brand on drugs" was so pushy that everyone just became a joke to everybody. So there's a way of doing this, and I think skating's a good way, but it's also a delicate way to do it as well. So
yeah, I agree. Very delicate. Kids in general don't like to be told what to do and don't like to feel as though they're being manipulated. By kids, I mean young people in general, people in general. That's particularly true within skateboard culture. So we have to just approach this very honestly and not pretend not try to sneak in any messages. We have to be overt about what we're saying, and we just have to share experiences honestly. If it at all comes across that we're kind of doing a campaign and we have a hidden agenda, I think it'll fall apart and we'll lose credibility very quickly. Yeah.
Awesome. Thank you. And we have one more question in the chat. Have you noticed any prevalence of ADHD in this community and included that in your approach at all?
Yeah.
You know,
rampant. Yeah.
The traits that are required for an individual to excel at skateboarding are interesting, and I think the skills that are required within skateboarding lend themselves well to somebody who may have ADHD, in the sense that it's very self-driven. You have to learn things on your own. It's very active. You're moving around. You're not sitting still. Nobody's telling you what to do. You're not following instructions. It's sort of self-driven and it's very creative. I think that type of activity, some people who are very rigid and risk averse will not excel in that situation. People who are a little bit more risk tolerant, maybe they appreciate or celebrate risk, but also are very creative and very active, often do very well in these types of activities. So I think the short answer, as Chris said, is yeah.
Great. Thank you so much again, Chris and Dr. Azar. We would have to move on to the next presentation. And we'll kindly ask you to stop sharing your screen so that the next presenter can share their screen.
Thanks, guys.
So thank you so much. So please help me welcome the next presenter, Leslie McBain, who's the co-founder of Mom Stop the Harm. So after her son's, Jordan's death, she became an advocate for more compassionate, evidence-based drug policies. So her presentation is titled, "Don't Call It Overdose." So Leslie, whenever you're ready, I'll start the timer.
Thank you. I'm ready. And I just want to say to those guys, my son had ADHD. He was a skater. He was sponsored by a small shop. He was completely high risk. He unfortunately died, but if he'd met you guys, I really think things could have been different. So thank you so much for everything you said and what you're doing. So my lightning round is called, "Hey, don't call it overdose." And I'm going to read this. So we are in an extreme epidemic of death due to toxic street supply of illicit drugs. We all know this. We say it every day. We see it every day. We wonder about it every day. What can be done? How do we fix it? Right off the bat, I will tell you there is no easy fix. I've been doing this for almost 10 years now, and there's so much more work to do. I would like to make it clear that the term overdose is misleading. It implies that a person took too much of a substance and it killed them. In a sense, that is true. If they take 1/2 grain of salt worth of fentanyl, they might live. But if they take a whole grain of mixed in with other garbage in the illicit drugs they bought on the street, it can kill them. We must continually change the narrative so that the public will understand what is happening here. It is not simple, it is complex, and the complexity can be explained. There's solutions, but they're not easy. Prohibition did not work in the early 1900s with alcohol simply because people wanted their alcohol. Prohibiting it was a dire error on all levels of government's part. Judgment. Gangs formed, as we know. Lethal product was created. People died. Families fell apart. So the government, in its infinite wisdom, decided to remove prohibition of alcohol and regulated and implemented its sale, collecting taxes along the way, of course. There's a similar dynamic with cannabis. Cannabis was prohibited. There were stiff fines in some jurisdictions. There were illegal grow-ops, which there still exist. And the police couldn't do anything but find the grow-ops and burn the cannabis. And I'll bet you some of those guys got high and really enjoyed it. So the government, again, realizing the law wasn't going to save people from the evils of cannabis, decided to legalize and regulate it. It was a brave move, we might think, but it was also pragmatism. Today, we have prohibition on some substances that are not legal, such as heroin, cocaine, methamphetamine, MDMA, and a few others. Did this stop the production, sale, and use of these substances? Of course not. People wanted to use them for all kinds of reasons. Some people just want to feel better for a moment. Some are addicted, and prohibition really just makes everything more difficult and dangerous. And here we are. A prohibition on drugs. Does this make people wary of a law and not use drugs? No, it does not. The law of prohibition has only made things worse because these substances are not regulated or legally available, and people who are addicted and others who may just want to access recreationally can only access the product that is so toxic it can kill you literally in a minute. So once again, we see that prohibition does not work. So why should we not call it an overdose? Because the term is misleading, as I said. It is called the toxic drug crisis. It is because we have allowed organized crime to provide the drugs people need and want. If we could only all listen to Lisa Lapointe, our amazing and retired BC chief coroner, now, and Bonnie Henry, chief medical officer, and BC's death review panel, and other leaders in the field, they will all tell you the way to stop the deaths. If the aforementioned drugs were regulated, legal, and had a wide regulated access, do you think more people would become addicted? The research shows that the conjecture is no, not more people would not become addicted. Do you think more people would die of toxic product? No, the answer is no, less people would die of toxic product. People, perhaps including your loved ones or friends, will continue to be harmed and even die from the use of black market drugs. Alcohol, legal and regulated as it is, still causes more harm and death than these illicit substances. But we let adults make their own decisions around consumption. Some may get addicted and most will not. Some people use alcohol in a responsible way. We don't hear much about alcohol overdose, although it does happen. But we still hear the term crisis of overdose or the overdose epidemic in regard to illicit substances. Let's do away with the prohibition of these drugs. Let us regulate and legalize these substances. Let them be accessed through compassion clubs, health regions, physicians, and there's other possible pathways. It will not be an easy task. It will take years. It will take infrastructure and certainly political will. And if we don't make sure that happens, we will continue to see 7 to 8 deaths every day in this province, 22 a day across the country, adding up to thousands a year. Now is the time. Well, actually yesterday and last month and 5 years ago and 10 years ago was the time to make these changes. Let's all take a perspective on this and fight for the safety of people who will use these substances. Thanks.
Thank you so much, Leslie, for a very inspirational talk. Like, it was very beautiful. So I'm also monitoring the chat right now. So we have the next 3 minutes to ask Leslie any question here. So please feel free to put it in the chat. I can start up with the first question. How does the language we use to describe substance use related incidents impacting like stigma and attitude towards individuals struggling with addiction? Because you did stress a lot on the word overdose and how we should not call it overdose. Yeah.
Well, actually the term overdose or toxic drug poisoning, those two, we're just trying to change the language to be more specific. And I don't think that the term overdose versus the term toxic drug poisoning, neither of them add to or reduce stigma. We have to be specific about what's going on here, and we have to be able to work towards that and towards ending the toxic drug crisis. Language is important. There is no question. This is a little bit off the topic of the question, but for instance, we who are advocates don't call people addicts. We say a person first language, a person who is addicted, or a person who is struggling with substances. It is people first. People are who we're talking about here. It's their lives we want to save. And if we want to save them, we have to agree on language. We have to have respectful language. We have to look at drug use and addiction as primarily a health concern, addiction as a health concern, and drug use recreationally is just a slightly different thing. I like the skateboard idea. Frankly, it's an absolutely great way to address kids that might be at risk.
Thank you so much, Leslie. We have another question in the chat here. Can you please tell us more about the work you do with Moms Stop the Harm?
Sure. Well, as was said, my son died in 2014 from an actual pharmaceutical drug overdose. It was an overdose. It wasn't toxic drugs. So two other women who had similarly lost their sons to drug harms decided, because not only were we grieving, but we were angry. We were really angry that we had no information, that we had no resources, or we couldn't find the resources. So we thought, okay, let's see who else is out there. We started the organization, with a Facebook page and a name and a website and so on. So what we do today is we sit on government committees, we advocate to government, we support people who have lost someone or people who have someone still struggling. We do everything we can to make sure that we're going in a direction governmentally and also just for the public that is going to mitigate this crisis. We don't want any more deaths. We don't want more addiction, but we know it's real. We know it has to, it's going to happen. So let's talk about addiction. Let's talk about dangerous drug use. So that's what we do. We try to educate, we try to support, and we try to talk to the government at every opportunity and media to educate the public and to change harmful drug policies.
Thank you. And just to be aware of time, but we do have one more question for you.
Okay.
How do we bring people together even more to help tackle this challenge?
That's a good question. That's a really good question. We struggle with that ourselves as an organization. How do we reach out? And I would say writing letters to your MLAs, your MPs, talking to your neighbors. You can hardly turn around without finding someone who has not been impacted by this crisis. So talking about it, carrying naloxone, not being afraid to talk about it or talk to people who are struggling. It's all about communication and education. So check out our website. There's lots of different ways that you can become involved, and yeah, just learn everything you can about the crisis.
Again, thank you so much, Leslie, for very, very great speech. And I will now introduce the next presenter. So our next presenter is Diana Hayati, and she is a fourth-year undergraduate student in the Integrated Sciences program at the University of British Columbia, integrating physiology and preventative medicine. She's also working as a research assistant at the UBC Addiction Concurrent Disorders Research Group. So for her presentation today, she'll be talking about her systematic review on fentanyl use and chronic pain. So Diana, whenever you're ready, I can start the timer.
Thank you for the introduction. So today I'll be talking about the systematic review on fentanyl use and chronic pain. For some background, chronic pain is the leading cause of global disease burden, affecting 1.9 billion people worldwide, and chronic pain is classified as pain that lasts more than 3 months. We all know that a globally important reason to use opioids is pain, where if unresolved can lead to self-medication. And today we'll explore how prescription opioids and pain management are a driver for the current opioid overdose crisis in North America, where fentanyl has become the dominant opioid of choice. The objectives are to describe the critical role of chronic pain in high-risk substance use and recognize the impact of chronic pain on opioid use in clinical settings. To gather data, the fentanyl cohort study examined fentanyl as the primary drug of choice among participants in Vancouver, BC. In this study, an interviewer conducted a questionnaire that covers fentanyl use and experiences with chronic pain. This method was used to understand usage patterns, associated risks, and impact of the healthcare system on those affected by overdose. So let's take a look at the combined results from the survey and the systematic review. It was seen that the majority of participants at 72.6% reported having chronic pain in the past 6 months, with 56.9% rating their pain to be greater than a 6 out of 10 on a given day. When asked about the relationship between their pain and opioid use, 65.4% identified self-medication as their main reason behind using, and 19.2% identified prescription opioids being inadequate, meaning not strong enough for their pain. To break down our results, observed are really high levels of pain that prescription opioids are not strong enough for. Individuals who use fentanyl to manage their pain often start with and prefer prescription opioids, but they're led to seek fentanyl due to its widespread availability, lower costs, and higher potency. So a strong relationship between insufficient pain management and unprescribed fentanyl use was seen in all major studies, where the difficulty accessing pain treatment through the medical system leads to a cycle of seeking opioids through external sources, forming a self-medication hypothesis. In regards to pain management in a clinical setting, there are 3 main barriers observed. Firstly, stigma around opioid use disorder is common, where patients may feel ashamed in asking for higher doses of pain medication, and providers are hesitant to prescribe stronger opioids from fear of diversion. Within this lies some misconceptions that maintenance opioid agonists provide pain relief and the fear of addiction relapse for people who use drugs. Next is the affordability of fentanyl. Despite available treatment, diverted fentanyl was often sought out due to its affordability and increased availability. And lastly, the challenging nature of opioid prescription itself is a barrier due to the many guidelines to treat pain with strict and complex dosing policies. These results show that current treatment modalities are inaccessible for many individuals, and even when they are accessible, they're inadequate for the level of pain experienced. Some beneficial changes to the current guidelines would be making addiction treatment as accessible as possible in conjunction with pain guidelines. In other words, the concurrent management of opioid use and pain. So as we've explored today, the critical role of chronic pain and high-risk substance use is evident in the increasing prevalence of chronic pain globally and its association with the opioid crisis. What this means is that inadequate pain relief drives continued opioid use, since it pushes people to seek unregulated fentanyl, increasing their overdose risk, which in turn makes the opioid crisis in British Columbia worse. Therefore, efforts to improve pain management should include standardized protocols, increase access to addiction treatment, and education to reduce stigma and improve patient-provider communication. And all in all, with ongoing efforts, there can be improved clinical care to ensure a better future for people living with concurrent disorders, such as chronic pain and high-risk substance use. Thank you for your attention.
Thank you so much, Diana. I'm again looking at the chat here. So we have one question in the chat. Can you talk about how to advocate for someone who needs stronger pain medications from their doctor, but their doctor is anti-opioid?
Right. So I think that really ties into what we talked about, how there's very complex, very different regulations and policies for prescribing opioids. So as we've seen, a lot of prescription opioids, even when prescribed, are inadequate. So I think this is just an overarching problem with the fact that there's many different guidelines that may contradict each other and not a very standardized science-based training or policy out there for prescribing opioids. So individually, I think it's difficult to give guidance on that, but then if we look systematically, definitely having more science-based management strategies for pain are important, as shown by this question.
This participant want to ask a follow-up question. They ask, how would you, what are the specific ways? Any suggestion that you have?
I think it's difficult for me to say, but maybe tying back into the point about stigma and being a little bit afraid to ask for higher doses, it was found that in clinical settings, more frequent patient and provider communication and assessment did improve pain outcomes. So maybe having more frequent check-ins with your doctor where you do express quantitatively how much pain you're in every day, although that may be difficult.
Right. Thank you so much, Diana. We do have just a comment in the chat that includes a resource. So Pain Care BC. Thank you so much, Casey, for including that. All right. So we will move on to the next presenter here. Thank you again, Diana. All right. So the next presenter is Harjeet Sudan. So she is a UBC neuroscience master's student at Neuroethics Canada, and she's passionate about health, equity, and justice. And she also recently received the CIHR Canada Graduate Scholarship Master's Award. So please help me welcome Harjeet. And her presentation will be on descripting the crypto markets trends over a decade of the dark web drug trade. So Harjeet, whenever you're ready, I can start the timer.
Sorry, I just lost my screen. There we go. All right, thanks Tam for that wonderful introduction. Thank you everyone for joining today. I'll be talking about some of my undergraduate work that I did at the Addictions and Concurrent Disorders group with Dr. Krause, looking at the dark web drug trade and some trends over time. So the internet is comprised of multiple layers, essentially going from most to least accessible. The dark web refers to the most inaccessible layer that can only be accessed using VPN and specialized browsers like the Onion router or Tor, as we see on the bottom here. And these other layers that we're more familiar with, like Google, Gmail, these are sort of more the surface layers of the web. The The dark web hosts various activities, including robust crypto markets that offer a wide range of listings, including weapons and stolen credit card information, and most abundantly, psychoactive substances. In fact, 2/3 of all listings on these crypto markets are actually psychoactive substances. So it's important to look at the dark web in these contexts because it offers a unique landscape for the drug trade, one that's highly anonymized, volatile, and unpredictable, meaning that it's quite difficult to regulate, and it operates on a global scale outside of the geographical confines of street markets. Most importantly, there is very limited literature and research on the dark web in general, with even less information available about the drug trade on the dark web. So to better understand the dark web's scope, relevance, and impact on drug crises around the world, we sought to characterize the availability and distribution of psychoactive substances over time on dark web crypto markets. We examined 14 data sets obtained from studies conducted between September 2012 and June 2019, and we simultaneously extracted drug listings related data from 13 crypto markets that were active between August 2022 and January 2023. And we were interested in looking at trends over time in these two different scopes. In the literature, we found 7 categories of substances that were most commonly reported and listed in the menu items of these crypto markets, and each included a diverse range of substances, including various novel psychoactive substances as well, synthetic opioids, all sorts of substances, as you can see listed here. When we compared the results from the literature review and our new data extraction from these markets, we found that the availability and distribution of different categories of substances have changed over the last 10 years. So you can see here the general breakdown of those. This figure depicts these results more clearly, as we can see here that the change in relative distribution of the prescription drugs, for example, the second set of bars, changes from about 25% of all substances that were available to roughly 5% in 2022 and 2023. Conversely, we find that opioids increase almost twofold. After mapping the chronological distributions and availability of different substances and their categories over time, we found a dynamic landscape for the drug trade. As we can see here, the relative distributions of different substances from each time point over the last decade is quite variable. These results are significant in the face of persisting overdose crises globally and shed light on the challenges and opportunities related to the dark web's role in these crises. So it poses major challenges to existing clinical systems of care and public health responses by possibly contributing to major shifts in the local and global drug trades, both on the streets and the internet, and many of these changes are unanticipated. However, we also see that the dark web can offer opportunities that can be leveraged for possible better and stronger responses to the drug crises we see globally. For example, crypto markets can be used for predicting changes in street markets by understanding demand and supply. We can also see that crypto markets can and may be used for and have been used for harm reduction. So most prominently, the Vancouver Drug User Liberation Front, or DULF, has previously purchased these substances in bulk on the dark web to test and then offer as safer supply. Lastly, changes in the drug trade on the crypto market can be seen as methods to evaluate drug policy, see what's working and what's not. We clearly see issues currently. Overall, our findings corroborate those in existing literature. So we see that there is a wide range of substances available for sale, and these markets are highly unstable and volatile. In fact, through the course of our research, actually, we had 29 markets that we initially intended to extract data from, and we were left with 13 that were existing by the end. So it's very up and down. And our study highlights that it's necessary to conduct further research on the dark web to better understand their role in global drug crises, anticipate and monitor changes, evaluate drug policy decisions, and to develop effective harm reduction strategies. And that's my presentation. Thank you for listening.
Thank you, Harjeev. Again, we have the 3 minutes of question and answer. And I'm looking at the chat here. So we can get started first with the first question. what challenges do researchers face in studying and understanding the dark web drug trade, and how did you navigate these challenges in your work?
That's a really great question. Thank you. Thank you for asking. This indeed was a challenging study to conduct. As I mentioned, the dark web is a very volatile space. Given that, like I said, 13 crypto markets were left from the 29 we had initially selected to extract data from. We see that there's a lot of closures, a lot of scam exits. So it's really hard to really understand what's happening in real time, which is why we conduct the study as a snapshot in time. That's one of our limitations, is that we collected data where it was possible from the markets that were available when we collected them. And then we've identified characteristics of each of these. Our paper that we published also lists a lot of the raw data. So you can really clearly see the sizes of these markets. So that's one way in which we can increase the transparency of reporting. In terms of the literature review that we conducted, we found 13 papers that reported 14 data sets of listings on the dark web. So that was down from the 5,000 plus papers that we screened initially for this type of data. So it's clear that there is there's many challenges to conducting this type of research, but there's a lot of robust algorithms and different programs that have been created in this space that have actually been used also to track data more longitudinally, so from defined time periods. And then I think those can offer a better understanding of what's available and how that changes over time.
Thank you so much again, Harjeet. Again, just to be aware of time, we have like only 1 minute left. So I think it's best maybe we can move on to the next presentation. But thanks again. And of course, if anyone has any other questions for Harjeet, please feel free to leave it in the chat. And if we have extra time, we can always discuss about it after. So the next presentation, we have Isabella Galelo. Please let me know if I'm pronouncing your name wrong anyway. So Isabella completed her undergraduate degree in molecular genetics, neuroscience, and psychology at the University of Toronto, and is currently a neuroscience PhD candidate in Dr. Jeremy Seaman's lab at UBC, and a member of Translational Medicine for Substance Use Disorders Research Lab. And her research focuses on the role of the anterior cingulate cortex in opioid withdrawal. So please help me welcome Isabella. So Isabella, whenever you're ready, please feel free to share your screen, and I'll start the timer.
All right, is everything looking good?
Yes, it's looking great from my end.
Okay, perfect. All right, so for my lightning talk, we're going to make a little bit of a shift into the preclinical world. And I'm going to be giving a presentation on how the anterior cingulate cortex and specifically changes in dopamine levels in the ACC may be responsible for producing opioid withdrawal-induced hyperkatifia. So to start off with some background, hyperkatifia is the hypersensitivity to emotional distress that people experience when access to opioids is prevented. So this can be thought of similar to hyperalgesia, where you have a hypersensitivity to pain. They have a hypersensitivity to emotional distress. And this provides motivation for drug seeking via negative reinforcement. So people are taking opioids in order to return their mood to a baseline level because the drugs have created this hyper-negative state that they're experiencing. So this was described by Dr. George Koob, and he lists a whole bunch of brain regions that he hypothesizes might be responsible for producing hyperkatifia, and one of those regions is the anterior cingulate cortex. And the ACC has a well-documented role in addiction historically, but the most important evidence of this comes from human studies where the ACC was actually surgically removed in people, and this was to treat either addiction or chronic pain. And in the cases of chronic pain, a lot of people had addiction to pharmaceutical opioids. And what we find in these studies is that for the majority of patients, they're able to maintain complete abstinence for years after the surgery. But most importantly, when you interview them immediately after the surgery, so the next day, they report no withdrawal symptoms despite having been completely addicted to the opioid less than 12 hours before. So one of the things that we know consistently from research is that in withdrawal, there's this increased activity in the anterior cingulate cortex. And when we reduce this activity back to normal, it's able to relieve the withdrawal symptoms. So one of the things that we think is responsible for changing ACC activity is changes in neurotransmitters. And specifically, we're looking at dopamine. So the mesocortical dopamine system is the system that connects the ventral tegmental area up to the medial prefrontal cortex. And that includes the anterior cingulate cortex, which is this brain region here. And we know that dysregulation of this system and the dopamine levels in the system is associated with many psychiatric disorders. But most importantly, from preclinical studies, we've shown that in withdrawal, the baseline level of dopamine in this brain region is greatly increased. And when we block this increase, we're then able to treat those withdrawal symptoms. So we see opioid withdrawals associated with this increase in extracellular dopamine in the medial prefrontal cortex. So our lab developed what we call the 3-valence task, and this is a behavioral task that we perform in rats, and it's intended to evoke different emotional outcomes. So briefly, in this task, we pair a tone with an outcome. So they have a tone that's paired to a rewarding outcome, a tone paired to an aversive outcome, and then a tone paired to no outcome, which is our baseline. And we present them in blocks of trials. And what I mean by that is they'll hear the tone and the food paired 20 times, and then that'll shift to the shock, or then that'll shift to the neutral. And when we record neuronal activity during this task, we see this figure on the left. And what you'll see is that the activity of the neurons gets locked into a unique pattern of activity, and that maintains for the entire block. So we don't just see changes in neuronal responses when the actual shock is occurring, but the time between when they experience shocks, that whole activity stays in that pattern. And it doesn't shift until the context then shifts to the rewarding or the neutral context. And what we took this to mean was that the ACC neurons are tracking the internal state that the animal is experiencing when they're in that block. And when that block shifts and their internal state shifts, that's when we see this shift in the anterior cingulate. So the question became, what is dopamine doing during this task to produce these shifts? So we repeated the 3-valence task, and this time we're looking at changes in dopamine levels with a technique known as fibrophotometry. And there's 3 key points to look at here. So the first is that we see dopamine responds to both the tone, which is occurring here at 10 seconds, and then the outcome at 15 seconds. And that's corresponding to just like what we saw in the ensemble activity. So we see changes in dopamine in response to both. The second thing is that we see dopamine increases regardless of the valence. So unlike the ensemble activity where the pattern of activity depended on if it was positive or negative or neutral, in dopamine, we see that it's increasing regardless of whether it's negative or neutral, and it's not the direction of change for the dopamine that is responsible for mapping where it relies. So what we took this to mean is that dopamine in the cingulate is encoding salience. So dopamine is spiking because something important is happening, and it doesn't matter if that thing is good or bad, it's important, it's spiking, and then the neurons themselves are representing whether it's good or bad. And then the final thing, which I think is the most important to look at here, is that there's changes in basal levels between blocks. And what I mean by that is if you look at the start point of where dopamine is in each block, in the neutral block, it's down here, and this is where their baseline is. But when it shifts to the positive block, their baseline level elevates. And then we get the greatest increase up here when we're in the shock block. So when they're in shock, their baseline dopamine is at the highest. And if you'll recall, as I told you earlier, we see that withdrawal increases baseline dopamine levels as well. So this is basically the hypothesis that we're working with here, that in withdrawal, people's baseline dopamine is at a level that's consistent with the level we see when they're in an emotional state that is aversive. So at baseline, they're perceiving everything as severely aversive because their dopamine is mapping it that way. So just to summarize everything, we know that in withdrawal, there's an increased ACC activity. We know that dopamine is responsible for modifying ACC activity. And we know that withdrawal affects the dopamine levels. So this is the working hypothesis of what is producing hyperkatifia, that it's alterations in the dopamine levels that are then causing neurons to respond to all events as aversive when they're in withdrawal, regardless of whether they actually are aversive. And then if we're able to restore these dopamine levels to baseline, hopefully we can then treat the emotional symptoms of withdrawal.
So thank you so much, Bella. So I guess we can start the 3-minute question and answer. So first question, how do the findings of your research contribute to our understanding of neurobiological basis of opioid withdrawal and inform the development of novel treatment strategies for opioid use disorder?
Yeah. So there's a couple things. That's a large question to unpack. The hope is that when we develop treatments, we need a target, like we need a mechanism that we're then trying to reverse, and we don't know what that mechanism is yet. So if we can come up with some clear mechanism for what is happening, we now have a clear target that our treatments can then alleviate. So I will eventually be testing out some compounds that we know work for treating withdrawal symptoms and see if they restore these dopamine changes that we see. And then that will hopefully lead to new compounds that can be tested.
So thank you so much again, Bella. We can't, unless there's any other question in the chat. All right, perfect. Then we can move on to the next presenter. Thank you again. All right, so for the next presenter is Tanise Epp. So Tanise is a neuroscience PhD student in the Hellman's research groups. She completed her Bachelor of Science in Honors Neuroscience and Mental Health at Carleton University in 2021, and her Master of Science in Neuroscience from the University of British Columbia in 2023. And her research interests include understanding the neural underpinnings of addiction and the impact of substance-related stigma. So please help me welcome Tanise. So of course, Tanise, whenever you're ready.
All right, thank you so much for having me. What a fun day so far, and the presentations have been great. Been hearing little sprinkles of stigma throughout everyone's presentation, so I hope I can provide a little more context here. So today I'll be talking about substance-specific stigma. Primarily what I'll be doing is actually providing a proposal for a new way to think about stigma. Well, in addition to how we already think about stigma, and then potentially a new measure of an objective measure of stigma. So without further ado, we already know stigma is this discriminatory attitude, belief, and behavior toward an individual or group of individuals who use substances, or just in general about substance use in specific. In terms of stigma, it's important that we learn about it, and it's important that we know more about it because it is the biggest barrier for people seeking and receiving treatment for substance use disorders. And the way we see it most prevalently is with the language we use. So in recent years, there's been this push to change language from just describing individuals who use substances to person-first language. And there's been a shift from moral kind of topics related to stigma to the more medical definitions of addiction, So within the DSM-5, there was the replacement of abuse and dependent categories with substance use disorders, so taking on that medical terminology, and that catalyzed the US and Canada to do the same within their own policies and within their own kind of government affiliations. So when we talk about stigma, and all I've been doing is talking about potentially the addiction or the dependence of substance use. But what about individuals who haven't received that diagnosis? What about everyone else who uses substances? Do they experience stigma? Well, recently, there's been a proposal for a new way to look at substance use as a substance use health framework. And this was proposed by the Community Addiction Peer Support Association here in Ottawa. This is where I'm at, and in collaboration with Ottawa Public Health. It describes substance use as a continuum. And we already know this, but the way we talk about substances is not on a continuum. It's only really on the severity end. But individuals will not use substances. Some people use it beneficially, as we've discussed kind of a little bit today. And then there's individuals who fall in the lower or higher risk that may not be able to access the same resources that individuals with the diagnoses are able to. So there is stigma across the spectrum that is experienced. For instance, we did a study recently that looked at Canadian undergraduate students who don't drink alcohol. not for any reason other than, so not a addiction reason, but for reasons outside of that. So it could be religion, could be family restraints, things like this. And they experienced a significant amount of stigma from their peers, and they were extremely lonely. And this was kind of the theme that came out. And so we don't really know much about these other phases of substance use. So it's really important for us to maybe, when we do stigma research, we start to look at this entire spectrum. But how do we measure stigma in general? Well, previously, one of the more well-known ways is a factorial study, where essentially you have this vignette, you use different words, and then you ask individuals to use answer a survey, and you get like the self-reported measure. If you're asking people really hard questions, there's going to be some biases involved, so this is very difficult to rely on, and so there's kind of a need for an objective measure. Currently in research, there's the implicit association test, and it's a behavioral measure of implicit bias. It's essentially a reaction-based task that requires you to do this test very fast, so it takes all of your kind of implicit moral biases that you have, and it obtains a measure of bias through this task. But with any reaction-based behavioral task, you kind of have some controversy there. There's a lot of different variables that contribute to reaction time, but maybe we can develop something above and beyond a behavioral task. And I'm proposing potentially a neural correlate of stigma. So my PhD work will be using electroencephalography to measure stigma. And how we propose to do that is using event-related potentials. And what that means is we're measuring the brain processes that happen after an event. So we can show a word like addict, and then we can measure top-down cognitive control of how they're able to answer this question, and then their measure of bias about 300 milliseconds after. So we can compare the EEG to our behavioral tasks and our self-report surveys and see how stigma is looking at all of these stages, as well as how it looks along the spectrum of substance use. So I hope today I was able to at least shed light on the substance use health spectrum, and then as a new potential way to use EEG in kind of a social neuroscience-y way. So thank you for listening. Happy to answer any questions.
Awesome. Thank you so much, Denise. So again, we'll start the 3-minute question and answer. So I guess the first question, how can healthcare providers or policymakers or community organizations utilize your findings to develop more effective strategy for reducing like substance-specific stigma?
That's a great question. I mean, this is something we're developing through time. Identifying that substance use happens on a continuum and it's not important just to look at the severe end or the addiction diagnoses end is really important for us in the preventative kind of way. So people who may be higher risk, their doctors may not be asking them questions about their substance use. So they might not be able to access resources that they might need until they're at a place where they are asking for help, and that might be too far along. So my suggestion is that we're talking about substance use earlier on and in more kind of strategic ways. Don't just wait until someone's coming to you with the need for help. We should be asking these questions earlier on and in a more open way. Because people can use substances beneficially, and that is everyone's right. And so we need to look at substance along a continuum and not necessarily just at a risk approach. So by looking at substance use health like we look at physical health or mental health, some days, we wake up and our tummy's hurting. We know there's something going on with our physical health, but the next day everything might be fine. We need to start looking at substance use in this way, and that way we can kind of have some earlier prevention that might, stop the stigma or reduce overdoses in this way.
Awesome. Thank you so much, Denise. We actually have a few questions and some comments here. First comments from Haley. This is so difficult, they would say. And they would say a dick is bad in that the word is a bad way to describe someone. Also, a lot of names could be considered both, not black or white.
I see.
And
so you're referring to the implicit association task, I assume. This implicit association task uses these very strong words that are supposed to pull out information regarding biases. So saying addict, of course, I agree. It's a very stigmatizing term. We shouldn't be using it. And that's what we need in order to do these behavioral tasks. But we also pair that with non-stigmatizing language as well. So a person with a substance use disorder. So there's kind of this back and forth. The example I provided in my slides with the black and white names is one that's done on racial bias. I don't do racial bias work, so I can't speak to that, but I agree. Stigma is a bad word, or addict is a bad word, sorry.
All right, we can try to squeeze in just one more question before we move on. So how can measuring EVPs and providing this neuroscience approach in stigma will be helpful in terms of reducing stigma?
Yeah, that's a really great question. And my approach to this is saying, once we can pinpoint what's happening in the brain in regards to stigma and how impactful it can be in the brain, we have more of a foundation to provide information on why it needs to be changed and why we need to look at ways we can change stigma. So a lot of the measures we currently use are very biased. Asking people about stigma is very hard to do. And then these behavioral measures, there's lots of variables in place. So by looking at the brain, we're providing potentially an unbiased, unconscious measure of stigma, which gets us kind of further along the way. And then we can look at whether educational interventions might change the way stigma looks in the brain. So there's lots of things we can do. It's very exciting.
All right, thanks again, Denise. We do have to move on to the next presenter now. All right. So last but not least, we have Karen Mills and Patrick May here today with us to present on Overdose Aftercare Peer Support Team. So Karen Mills is a Métis with 26 years of lived experience in substance use, poverty, and homelessness. She's the founder of Peer-to-Peer Indigenous Society in Victoria, BC. She has a degree in mental health and substance use and is pursuing her master's in addiction medicine. And Patrick May has 30 years of lived experience in alcohol consumption, and he's also a retired chef. He's a co-founder of Peer-to-Peer Indigenous Society, and he's also an outreach coordinator for the organization. All right, so please help us welcome Karen Mills and Patrick May. Yeah, so whenever you're ready.
Sure. Thanks. Patrick had to go or at work. So I have 26 years of lived experience in substance use and overdoses. So I wrote this program for Island Health and got a grant for it. When people are experiencing an overdose, it's pretty scary. I just want to mention I worked in harm reduction for 9 years, so I saved a lot of lives, over 200. So when someone, when you're harm reduction worker, working in that field, your job is to save someone's life from a non-toxic, fatal overdose, and then the work stops there. That's where it ends. So I programmed because I remember when I overdosed, it was pretty scary. And I had to keep using because I was addicted to substances, and so that fear was always there that I was going to overdose over, again, and obviously. So I created this program, and basically we work with Island Health, we work with the consumption sites, any other service providers that are dealing with toxic overdoses. They will give us a call, and we will come and meet that person. there's a lot of people that choose not to go to the hospital because of stigmatization of being a substance user when you get there. And also after if you get some care, you're stuck. You can't get back to where you were. So our job will be, we'll connect with service providers and people that have experience in overdose. And if they wish to go up to the hospital, we'll accompany them and advocate for, if they choose to hit a different path, such as OAT or MAT, or whatever, so that they're advocate for them. And then we also have a weekly peer group, and that's people with lived experience of substance use and people with lived experience of overdoses, where there's a safe place to talk, maybe plant that seed of recovery at that time, or just listen to people. And that's the program. Yeah.
All right. Thank you so much, Karen, for sharing. I guess we can start the question and answer right away. And of course, we do have to end the session at around 12:30, but of course, we do want to give enough time for you to answer your questions as well.
Right.
So I guess to end on a good note or a positive note, maybe can you share with us any success stories or outcomes that highlight the impact of the work that your team does on individuals' recovery journeys? Oh, I think I'm not sure if it might be on my end, but I'm not hearing, I can't hear you. Sorry. Maybe some technical difficulties here. Do you mind trying maybe mute and unmute yourself again? Or I'm not sure. Hi, Kara, do you mind trying to speak again? I'm not sure if this is gonna work this time. But you can hear me, right? Okay. Unfortunately, since we can't hear you, and there are actually a few more questions coming in for you here. Maybe so I can just read out the questions, but of course, Karen, if you don't mind, maybe just you can also type in the chat the way that people can contact you to ask you these questions or just to have a chat with you. So the first question is, how long do you tend to work with individuals, and do you find it's once or twice or on a longer term basis? So that's the first question. Yeah, I believe the second question seems to be for previous presentation. NA uses the word addict, and so clients who go to their meetings use the term, and it is hard to get them to use better language. Yes, so sorry, Karen, since it seems like we are not able to hear you. Maybe would you mind maybe answer the questions just via email if we send these to you? Well, just to also be mindful of the time. And of course, I want to thank everyone for all your very attentive participation. And we'll now have a quick lunch break and hope to see you all again at the last keynote session at 1:30 p.m. And of course, don't forget to cast your vote before you leave the session, and vote for your favorite talk on Feed Loop to help us recognize the outstanding contributions of all of our presenters today. And of course, enjoy the rest of your of the conference. All right. Okay, thank you again.